Motown Ultrasound shorts. Chris is going to take you through a case he recently had.
Alrighty. So we had a patient come into the resus bay, 50-year-old male, no past medical history, no family history, no drugs, nothing. Chest pain while he was at rest. Started walking across the kitchen, collapsed to the floor, it hurt so bad. Vital signs showed he was afebrile, normal heart rate, blood pressure was a little low, and the real thing that was abnormal with him is he really looked sick. The rest of his exam was relatively unremarkable. Obviously, the first thing we do is get an EKG. We took a look at it. It doesn't really show any signs of major ischemia, no T-wave inversions, no big ST segment changes. And then we took a look at the heart.
Ooh.
Well, his heart's here.
Whose heart was that?
That was Mr. Bob's heart.
Okay.
Well, we have this x-ray here. First thing you need to notice is it's an AP view. So the heart looks a little bit big, and that's just because it's AP. And the other thing is the mediastinum looks enlarged as well. Again, but that can be a finding just on an AP film, but it's something you need to recognize. So what would be your differential at this point, Dr. Dowers?
Well, if we're talking about a 50-year-old with kind of chest pain and maybe syncope, he fell to the floor. Big things I'd be worried about, one would be like a pulmonary embolism, but number two, especially looking at that chest x-ray, would be if he had an aortic dissection.
Perfect.
I'd throw a little aneurysm in there, or maybe just still consider ACS, despite no EKG changes.
And that's exactly what we did in this case. We sent blood for troponin, BNP, and then obviously we were concerned for dissection as well. He did get a CAT scan. However, the whole point of this whole talk is to use ultrasound. Diagnosing aortic dissection, there's a bunch of different imaging modalities. This is a JAMA review article from 2016. And as you can see, CT and MRI are really our gold standard. Back in the day, it used to be aortography. However, now the CT is very sensitive and very specific. Now, for ultrasound, TEE is really the way to go, transesophageal echo. However, for transthoracic echo, you can see the numbers here. They're not great, 73 to 100% sensitivity versus 71 to 91% specificity. And this is just from two articles in the mid-90s. So they haven't really been reviewed any further recently. Right now we're going to focus on evaluating the thoracic aorta with echo, transthoracic echo in particular. So we're going to focus on suprasternal notch. We're going to use the phased array or microconvex probe. The big thing is putting a roll or pillow behind the shoulder and have the patient hyperextend their neck if possible. And that's just so you can jam it on in there and then not hit their chin. For long axis view, the 1980 paper about how to do this was kind of spot on with keeping your plane between the right nipple and left scapular tip. There's a bunch of different ways that you can use echo to evaluate the ascending arch and descending aorta. We're really just going to focus on suprasternal, but you can do echo for parasternal long, short, apical two-chamber, you can see it. And again, transesophageal echo is really good. That's like your aorta right there. So the first view, looking at long axis, remember right nipple to left scapular tip, indicator about 2 o'clock with your chin being 12 o'clock. And you're seeing here your aortic arch, and you're seeing all the different branches coming off. The way to really find this is to put color flow over the image initially, and then you'll find out where the aorta is, and then kind of fine-tuning your 2D image to kind of get all those different pictures. Back to our patient. This was his view of his aortic arch, and if you look very closely, you can see a dissection flap just above where the right pulmonary artery comes through. We then put color flow just again to kind of confirm that this is the aorta. We're not seeing a really large filling defect, but you don't necessarily have to, since it's just a small intimal flap.
So you can usually use color flow to identify direction and speed of flow. However, we're getting a mix of signal through this aortic arch here. You're seeing red and blue, not kind of one discrete red side and one discrete blue side. What's happening there is we're just exceeding the Nyquist limit. So if we had increased our scale, we'd be able to see a nice red side and a nice blue side for the descending arch.
Next, we moved into the suprasternal view short axis. So from our long axis view, we're rotating clockwise to about a 5 o'clock position. And this is really trying to get a cross-sectional view of the aorta. When you're looking at this, you can see the right pulmonary artery right behind it again, but this time in long axis. Remember last time it was in short axis. You can also see the SVC kind of draining down as well. Our image isn't as pretty as that picture. Probably because we're just under-rotated. However, you can actually see a small area of dissection flap in this image as well. Alright, now we're looking at the peristernal long and short axis views. Again, remember our sensitivity and specificity for transthoracic echo is kind of a large range. And this is because if you're looking at these images, you can't really make a diagnostic decision on them. For the peristernal long, we're focusing on the aortic valve and the LVOT. We're not seeing a big dissection flap at this area. And then for peristernal short, we're looking deep to the peristernal short axis at the descending thoracic aorta and long axis. And again, we're just not seeing it well here. We actually had another case yesterday of we saw the descending thoracic aorta really well. You can see it right here.
And I found that for getting that view, it's actually easiest to start peristernal long, identify the descending thoracic aorta in your peristernal long, and then rotate the indicator, focusing on the descending thoracic aorta instead of focusing on the heart like you normally do when switching from peristernal long axis to short. That's what helped us get that clearer view.
Yeah, I typically agree and find that to get the aorta lined up in that long axis, I typically have to rotate the probe more towards the mid-clavicle line on the patient's left side than towards the shoulder.
And then just for this patient, we didn't actually do any apical imaging, but you can see the descending thoracic aorta and long axis with an apical 2 window. This is the abdominal imaging, and we're kind of off to the patient's left a little bit. However, you can see a dissection flap within the abdominal aorta right here. Now it's time for the CAT scan. Pause for effect. Perfect. Now for the truth machine. Love the truth machine.
I call it the diagnosis machine.
And we're seeing the aortic dissection that you already diagnosed with ultrasound, extending from the coronary cusps through bilateral iliacs. So just briefly, you have type A and type B, Stanford classification. Type A needs surgery, type B typically medical management. This was a type A dissection, so the patient needed to go to the OR. And that's it.
So thank you for watching our first episode of Ultrasound Shorts. Remember, you can follow us at Twitter at Motown Sono 1, and stay tuned for more Ultrasound Shorts.